Hi and welcome back. In today's video, we are talking once more to Dr. Robert Mathis, or as I like to call him, Dr. Bob, an MD in Santa Barbara, California. Dr. Bob has been on my channel, I believe, 4 times. If you have missed any of those videos, I will link them down below. Now, as dramatic as it sounds, about 15 years ago, Dr. Bob saved my life. I talk about this in a different video, which I will also link down below. Dr. Bob's knowledge and his passion to help women is so incredible, and I know he has helped many of you as well. So in today's video, we are talking about hormones and hormone replacement, the risks, the benefits, and everything in between. So without further ado, let's talk to Dr. Bob. It is so great to have you back with us.
Thank you. Hello.
Thank you so much for being here.
You're welcome.
You and I have done quite a few videos, and they have been so incredibly helpful to so many women. But every once in a while, I get a comment under the videos of a woman saying, isn't it normal to go into menopause? Why are we replacing hormones? Why are we messing with nature? Our mothers and grandmothers didn't do this. Why are we doing this? And I actually heard a doctor say the other day, it was Dr. Hunter, who I also had on my channel. She said, we stop replacing hormones when we get ready to die.
The women ask me, they say, well, how long should I take these hormones? I said, take them as long as you want to feel good.
But how do you feel about this? We are obviously messing with nature, and maybe our ancestors didn't do this, but how do you tell us your opinion on this?
Okay, so there is no plan. There's no plan for after the hormone cycles are gone. Mother Nature just says when women can't produce children, then there's no use for them. And that's completely false, but that's what Mother Nature says. So there's no plan after the hormones are gone. What's interesting is that women seem to have this little bit of testosterone so they can kind of survive for a while. A lot of people have very small amounts, and a few women have enough to survive nicely. Most women have a lot of problems with menopause because there's no plan. Mother Nature doesn't have a plan. And that's why the hormones, if you're talking about Central America, you're talking about South America, you're talking about many places all over the globe, there are no hormone replacements. Basically, the United States, to some extent Canada, and parts of probably the UK and so forth, they have some sophisticated hormone replacement capability, but that's just the rest of the world. These women suffer in silence. It's not fair. It's unhealthy, and the family loses their mom. You know, the husbands lose their wives. This is what happens when there's no hormones. And every day women call me literally in tears because they feel so bad they can't function. So I'm sorry, but Mother Nature just hasn't made a plan. And I don't know who did this, but if he comes down here to talk to me, I'm gonna let him know. He didn't do a good job on this.
Do you think that we suffer more now? Do you think maybe because of environmental toxins, lifestyle, all of these things, we suffer more now than our ancestors did? Or did they just die sooner? Why do you think we struggle more now with menopause? Seemingly.
Okay, so there's probably a multiple number of reasons why, including the toxins and that not including the stress level. I mean, our stresses today are so extreme, especially with the last 2 years, we've really just been impaled by stress. So there's been a lot of stresses for women, a lot of demands on women's time. And I think that it's just a whole group of things that cause this. I know there's a lot of women who went through menopause in the previous generation who were born in the late 1800s. And the answer is yes, some of them suffered horribly, quietly. They just didn't. They were basically dysfunctional, but they somehow snuck through it. But today it's impractical because people need to be functional. They need to be part of a family. They need to help with their kids and so forth. And our life is just so busy. So I think you're right. I think it's the chemicals, the toxins, the stress levels. Sleep is just, it's critical. And people who don't sleep don't do well.
Well, and if your hormones are low, then you don't sleep well. So it's this,
you don't sleep.
this cycle.
No.
Yeah.
No, you don't. Neither men nor women sleep when men don't have hormones, which I'm noticing. I have a couple of men who recently had prostate cancer, and they gave them the hormone therapy, which reduces their testosterone down to nothing. If they don't do something within 6 to 7, 8, 9 months, these guys will die because they can't live without hormones. Nobody can. It's a tough choice. And you just have to decide if you're going to have a quality of life or not.
So you agree with Dr. Hunter, you stop replacing hormones when you're getting ready to die?
I just tell people, when you want to stop feeling good, you can stop the hormones. I have people in their late 70s, early 80s. I have a few people call me up and they'll say, she's like 83, the last person a few years ago. I got to have those hormones. She's 83. I said, you want to go on the rhythmic? Yeah, I want the rhythmic program. And she's on them now. And, with Alzheimer's, there's a book by Dr. Brednison about end Alzheimer's. Mm-hmm. And in his book, his plan, you can get a copy of his plan in the back of the book, or people can ask me for it. And in his plan, it's fix the hormones. Give men testosterone, give women some estradiol, right in his plan. If you want to keep the brain working, part of his amazing plan to end Alzheimer's.
And I think there is a little bit more awareness now that we do now know that hormones can help prevent certain diseases, but I think there is still that fear factor too, but don't they cause cancer? And that is, I think, where women are still so afraid and why they think, if I go on hormones, I'm just going to be on them for a little while so that nothing bad happens. What do you say to that? I know your opinion on that, but let's talk about it.
So what I have observed is that in the 15 years I've been doing this, I had 3 people who put on the hormones, and within 6 months, something appeared in the breast. So what does that mean? In my world, that's an early warning system. Breast cancer is a 15 to 20 year disease. It takes 15 to 20 years for this disease to manifest. A lot of people don't understand that, but when you read the literature, that's what they talk about. So this woman puts on the hormones. She's already got something going on, some aberrant cells that aren't happy. They're not doing their job right. And we can call them dysplasia. We can call them cancer, depending on where they are. And the answer is the estrogen causes the growth to increase, which brings them to the surface so they can be seen and dealt with. A couple of people had lumpectomies. They were done. There was nothing else to do. And then they put the hormones back on and nothing shows up. So that means they're clear. Dr. Taguchi, who is an oncologist here in Santa Barbara, she's had a long-term study with her women after breast cancer. She's got 2 groups. The ones that put on the hormones and start the rhythm back up, and the ones that don't. The ones that don't use the hormones have more recurrence of cancer than the ones who put the hormones on. And she's discovered a significant difference. So there is a long-term study going on right now. It's a 3 to 5 year study with a women's group down in Los Angeles. And that group will have results in about 3 years, comparing hormones to no hormones to the rhythmic hormones. So we'll have some answers there for the first time, real answers about hormone rhythms and so forth.
Good.
So I think it's an early warning system. I think that estrogen actually saved these people's lives, not interfering with their life, but saving their life, because it helped this thing show up. It would have still smoldered along. It would have gone along for the next 5 or 6, 7 years. And then by the time 10 years passed, it would be all over the place and it would be too late. So I think it's an early warning system.
If you think about it logically, I mean, obviously you can get cancer in your younger years too, but for the most part, we get cancer and disease as we are aging when we have no hormones. So logically, that would tell us it's not the hormones causing these diseases, but the lack of hormones.
Cancer is an inflammatory disease. In my studies, inflammation, I saw a chart once and it had a little bit of inflammation here, more, and then cancer at the other end. And it's like, as the system gets more and more inflamed, the cells have more trouble trying to survive correctly in that environment. And all that inflammation eventually adds up to dysregulation of the cell, especially in the case of mold, for example. There's a lot going on with mold and inflammation. And I have patients that suffer from mold toxicity because that same idea, they just become very inflamed. I think that it's really an inflammatory disease. And then I said the hormones are an early warning system. If something's going on, you find out right away.
I've heard you say before that estrogen and sex hormones are actually anti-inflammatory, correct?
Correct. Estrogen will lower your A1C. Estrogen lowers the inflammation. Estrogen helps with arthritis and aches and pains. It's amazing what it does. Not progesterone. Progesterone can kind of aggravate a little bit, but estradiol does that.
What do you say to somebody? Well, first of all, let's talk about this. So I have made several videos talking about my struggles with hormones. You know, by the time I came to see you, I was ready to jump off a cliff. I had tried, I don't know, 6, 7 different hormone replacements, and none of them did anything. And when I talk about my struggles and then say I met you and you gave me something and it worked like a charm, people don't understand why, if you've been on hormone replacement before, why didn't that work, and why did what Dr. Mathis gave you worked? So talk a little bit about that, please.
Number one is hormones can be made a lot of different ways. And the components of the hormone, for example, creams, can be made with different base creams, different crystal sizes of the estrogen crystals. And then the pharmacies, what happens is recently I've had a few women, and I've tried to go to their local pharmacy, their local compounder, and we found out that they just don't do a very good job of making them. They don't mix them as well as they should. So the women don't do well, and the numbers don't come up where they belong. So I'm available. I take phone calls, brief phone calls. I got one today. She said, "Can I talk to you for 5 minutes?" And I said, "Fine." There's no charge for that. And we're going to do a couple things after that conversation. And the answer is, when something doesn't work, we have to go to the next plan, the next base cream, the next pharmacy. So the answer is, I have a couple of pharmacies that I like that really do a great job. Those are, I call my flagship pharmacies, who actually know how to make the creams correctly and do a good job consistently. And so when I go to that pharmacy, I pretty much know they're going to do a good job. Now I have to decide, does that cream, base cream, and that crystals that they got that shipment from, whatever, does that all go together with that woman? A lot of times it does. Sometimes it doesn't. So we have to go back to the board. I have somebody who recently I had to change the base cream on her. We went from HRT cream to Lipoderm, and we're expecting that to be more absorptive for her and to do better for her. And then, of course, the good news is she can call me, she can text me, and she can say, "Okay, it's working. Okay, it's not working." There's instant access, and that makes a difference. So we can keep moving and get it to work for her. And if they don't have that kind of access, you can't wait 3 months.
Yeah.
You can't wait 6 months to talk to your provider.
Now, for me, I was actually not even on I was on bioidentical hormones, but I wasn't on transdermal bioidentical hormones. I was on capsules. I was on sublingual pellets. I was on an estrogen patch. So I was on all these different delivery methods, which didn't work for me. They work for some women, they don't work for me. So it's just trial and error, correct?
It's pretty much, well, it's great if the provider has a pretty good understanding of hormones. And without being too difficult, it seems like some providers are not that clear about dosing. Recently, I've had some women whose testosterone have been in the 300 to 500 range, which is way too high.
Yeah.
And one person was told by her provider that that's okay, that she wants it to be around 300. I'm going, no, you don't want it to be 300. Somebody might die in the house. The woman gets aggressive and whack the husband. That's too much testosterone, and it overpowers any estradiol. And it seems like there's a general fear of estradiol among the providers because they give such small doses, and they give the biased or such tiny doses of estrogen. As a result, the women just don't feel the primary hormone is estradiol. You've got to give the real hormone, or you're not going to get the results, and they're not going to feel good. And you just have to have somebody who you work with and who you can call and talk about it, and then make the changes, and who understands enough of that to be able to do that. Plus, it takes a lot of time.
Yeah.
And you can't charge for every second you're on the phone. The goal is to make the person feel good. The goal is to get that phone call like I got from a woman the other day. "I feel the best I've felt in years." Payment in full.
Yeah. And to treat, what I didn't experience before until I met you is I wasn't treated as an individual. I was told, this works for all the other women who I give this to. I don't know why it doesn't work for you. And you really look at somebody as an individual. If it doesn't work, well, then let's try something else because you're different. And that's something that is, I think, that has made it work. And that is why you and I work together. But you just mentioned testosterone numbers. So let's talk about really briefly, because I get that question quite a lot. I get emails from women all the time. They tell me the estrogen is 7 or 5, which is, I don't even know how they function. Where do you like to have an estrogen number? What is an ideal estrogen number for a woman to feel good?
Generally, I feel that the estrogen has to be over 100 before they start to feel anything. Mm-hmm. So somewhere between 125 and 200 is probably a good range. Okay. As long as there's plenty of progesterone to balance it. I have people that on a regular basis have estrogen levels at 30 or 40, and the doctor says, yeah, you're good. That's it. You're good. You're in the range. And I'm going, what range? You're in the menopause range.
You're normal for your age. Exactly. And that's not what we want.
You're normal, but is that normal? And the answer is Mother Nature did not make a plan. It's like she drops women on their head as soon as the cycles are gone. And it's totally unfair. So I'm mad at the big guy for not having a better plan.
How soon do you think a woman should start to worry about checking her hormones?
So we have two choices. One is, to me, it's okay to, in your 30s, to check them, to see what's going on and just get a baseline. Get a day 11, 12, get a day 20, 21, see what your baseline is so you know what your kind of hormones were like when you were younger. And then option B is, you can, when you're in the mid 40s, you can grab some numbers and see how they are. That's probably a little late to get a baseline, but that'll give you some way of let you know what's going on, because it takes years for the hormones to drop off. They don't drop off overnight. It takes 3 to 5 years for those cycles to stop. The system just fatigues and it can no longer produce eggs, and therefore there's no more estrogen.
Talking about testing, I actually saw a doctor here in France a little while ago, and I wanted her to test my estrogen. And she said to me, oh, we don't test hormones because they constantly change. How do you feel about that?
Okay, so, the female cycle is very precise. On day 11, 12, there's going to be an estradiol peak on a 28-day cycle. On day 20, 21, there'll be an estrogen progesterone peak. Testosterone peaks around day 16 or 17, somewhere in there, but testosterone is not the key hormone. The real hormone is estradiol and progesterone in balance, about 20-to-1 ratio. So that statement is incorrect. If you understand the female cycle, you know that there's 2 points where you can check them and see what's going on. You just check those 2 days, day 11, 12, or 12, day 20, 21. You can check them anytime you want, but those are the days we're looking for the peak estrogen and progesterone. That's what we're looking for.
That doctor just showed to me the ignorance there still is around hormones and hormone replacement. If I was diabetic, she would measure my blood sugar, even though that changes constantly as well. We get treatment for diabetes, for high blood pressure, all of these things, but your hormones are gone, and it's just, well, that's just how it is.
Yeah.
It's really sad. Yeah. It's quite sad. Now,
it's a disaster.
Yeah.
I mean, I had a PhD student come in, and she was just, I can't write my papers. I can't function. I can't graduate. She was about 47, and I said, hey, hang in there. We're going to put you on some hormones. She comes back in 2 weeks. She says, I can write that paper in 3 minutes. I'm good. Everything's good. Yeah. And she graduated. So
what do you say if a woman has been in menopause for a while, they're in their 60s or 70s, and they haven't had hormones for 10, 20 years? Is it too late? Can they still get benefits of hormone replacement? Are there any dangers?
The answer to that one is I have women who come in 10 years post-menopause. It's okay to start the hormones. I tend to start them slowly, because what you're going to do is you're going to wake up those tissues that are hormone sensitive. The vaginal tissues, the uterine tissues, the breast tissues, they all wake up because the hormones are back. And it's just normal. They just wake up and go back to work because they get the messages they're supposed to receive if we do a rhythmic method. If we do a static dose, it's okay too. There's no cycles. The tissues still wake up. I have women come in their 70s and 80s. I had a woman a couple of years ago she was, I think, late 70s, had breast cancer, and nobody would touch her. They won't give her any hormones, and she felt terrible. She hasn't got any quality of life. I said, well, you can do this, but we have to monitor you closely and, do the mammos, whatever we have to do. She's done really well. There's been no recurrence. And if there was something there, the estrogen would have caused it to pop its head up right away. So that's, again, like a fail safe. I mean, it's like you put the hormones on, and if there's some bad guys there, they're going to wake up, and the hormones wake them up, and then we can see them right away. Yes, you can start them later. Just start slow.
But they definitely will still have benefits as far as, could you even reverse bone density? If there's a weakened bone density, is there some reversal?
When you do the rhythmic hormones, which is either physiologic restoration is one program, another one's called the Wiley protocol. When you use protocols that include rhythm, where the hormones are doing what they're supposed to do, as if you were 25 to 45, the answer is the bone density reverses. And I've seen the bone density go from minus 2.5 back up to normal, because the estrogen and the progesterone break the bone, build the bone, break the bone, build the bone, based on what you're doing physiologically and how much pressure you're putting on the bones, how much you're carrying. And so the bones get remodeled properly by the hormones. You don't need Fosamax. You don't need bone density drugs. The hormones will rebuild those.
I know so many older women who don't have any hormones. They have been in menopause for a long time. They are on medicine for the bone density. They are on antidepressants. They are on sleep medications. Yep. All of those things could be taken care of by just replacing the hormones.
If you replace the hormones, you're going to improve the serotonin level and probably will not need any antidepressants. You can also give some amino acids to support the estrogen to help build serotonin. The bone density comes back, the muscle coordination comes back, the muscle bulk comes back. You're rebuilding the vascular tree with the estradiol.
Somebody asked me if their hormones are balanced, so if they go on hormone replacement, then they balance the hormones. Does the menopausal belly fat go away?
In theory, things work a lot better with the hormones. And so you're going to feel better. You're going to have a better lifestyle. You're going to be able to go out and exercise. You're going to sleep better. You're not going to get the insulin resistance from not sleeping, because that's one of the things that happens with insomnia. You get the insulin resistance, your A1C starts to climb slowly, and insulin resistance is the beginning of weight gain.
So you keep mentioning rhythmic replacement. Let's talk really briefly, because I don't think a lot of people understand what that really means. Let's talk really briefly about what does that mean, rhythmic hormone replacement.
When I have a new patient, I explain to her that she has two choices. One is she can have static dose, estrogen, same dose every day, progesterone, same dose every night. That's static dose. Now, static dose does not take advantage of all the physiologic changes that are associated with rhythmic hormones. So as the eggs are recruited by FSH, there's 3 to 5, maybe 6 or 7 eggs tops that are recruited. And those eggs mature up to day 12, at which point they stop growing. And then estrogen falls. And as estrogen falls, there's triggers in that falling level of estradiol that produce something called P53, which goes after aberrant and unhealthy cells and kills them. So there's a cleanup crew. You know, it's kind of like the self-cleaning oven. The answer is we have a self-cleaning system, and it goes after those cells that aren't good, and it gets rid of them, which is great. That gets triggered by the downfall of estradiol between day 12 and day 14, 13, 14, 15. So that's one thing. The other thing is the LH surge happens when that fall occurs, and LH produces some progesterone reception, and then that allows you to receive the progesterone. If you don't have that happening, it's hard to receive it. But the answer is there's a lot of physiologic mechanisms happening. There's 4 distinct histologic cycles of the breast tissue itself. It goes through 4 distinct cycles throughout a 28-day period. I mean, the woman's body is in motion all the time. It's getting ready for a pregnancy, or it's completing a cycle and getting ready for another pregnancy or whatever. And so the woman's body is in motion all the time, unlike men. Crazy guys. Totally different. But women are moving. Their bodies are moving all the time, getting ready to do the next phase of the cycle.
With the rhythmic hormone replacement, you are mimicking this natural cycle that we have when we are younger.
You're mimicking the cycle. You're producing those physiologic changes. You're optimizing. The bone density goes back up to where it's supposed to be. The vascular tree, the heart, the brain, there's estrogen receptors on the mitochondria, so in the brain. So estrogen is there to help regulate energy flow in the brain and so forth.
It shows you again how little some doctors know about the benefits of hormones, because I have talked to other doctors about I am on a rhythmic hormone replacement. And
Right.
several doctors have said to me, why would you want to do that? Why would you want to go up and down in your mood? And why wouldn't you always want to feel the same? Basically, why wouldn't you want to be on a static dose? Because they don't know all those benefits.
Those benefits are very real. There's all these messages that are being transmitted by the hormones. And those hormone messages are creating the cycle. They're creating the life-sustaining systems that go out and kill the defective cells. I mean, it cause apoptosis, programmed apoptosis, and so forth. It's Mother Nature at her best.
How do you feel about, for women that are a little bit worried about taking hormone replacement as far as estrogen metabolism, all of that, how do you feel about taking things such as DIM to help a little bit with estrogen metabolism?
Methylation is an important part of our life. We need to have a good methylation cycle. There's a couple of labs that have some very sophisticated methylation testing that can be done. It's not done very often, but it can be done. There's some excellent products out there to help support methylation so that you can break that estradiol, which turns into estrone, which then has to be turned into, instead of 2-hydroxyestrone, it has to be turned into 2-methoxyestrone. That's through methylation. And then there's 16-methoxy, and then there's 2-methoxy. You have to convert this, and DIM helps you do that. Mm-hmm. So you can check the methylation cycle, you can support it with a couple of really great products, and then you can even measure it. There's the thing called the Dutch test, which you may have talked about with your women, and the answer is you can actually look right at the methylation products that are happening with the hormones. This is one reason why I don't like oral hormones, because, for example, I have a woman right now who her estrone is over 500. Her estradiol is 60, but her estrone is 500. So she took the oral pill, and she's got about a 10% conversion to estradiol and 90% conversion to estrone. So she can't do oral hormones. That doesn't work. It doesn't work for really anybody, but she can't do it. And there's the evidence of it. Her body has to metabolize that estrone all out of the body. Mm-hmm. So she needs a very strong methylation cycle, or she needs the support of DIM and a methylation cycle to move that estrone out. And option B is just take her off the oral hormones. So that's what we're going to do. We're going to move her away from oral so she doesn't shunt so much estradiol into estrone.
What's the problem with having too much estrone versus estradiol?
So estrone can convert, the 4-hydroxyestrone can convert into some inflammatory materials, into some inflammatory metabolites. So there are people in the literature that talk about 4-hydroxy being a problem and may in fact cause, the big C. They say, well, maybe that causes cancer. Well, the answer is it causes inflammation, and the inflammation is what leads to the cancer problem. So you do need methylation to work. So if you have good methylation, it goes this way over to its methylation byproduct. If methylation is not that strong, you go into these other metabolites, which are inflammatory. I don't like DHEA very much because I don't want to have to deal with too much estrone. If you keep the estrone level low, which in a normal, the way I use hormones, whether it's a patch, a cream you put on, or a gel, most of the time women don't convert too much of that. About half, it's about equal estrone and estradiol, and that's easily managed with decent methylation or with the addition of DIM. So, and if you don't check the estrone, you're never going to know what it is. Okay. And one of my professors said, well, I kept asking, why am I seeing estrones like this? And he said, well, if you don't like the number, then don't order the test.
But that is...
I want to know what's going on. I'm not going to just put my head in the sand. So when I want to know, I order an estrone and I can see what she's doing with her hormones.
So that is something you suggest if women are on hormone replacement therapy, check your estrone here and there?
Most of the time with the creams or the patches, there isn't too much conversion because there's that first pass liver phenomena doesn't happen. But when you take them orally, or you take we did a study with oil. We put estradiol in olive oil and they took it orally. Oh, geez. The estrone levels were like through the thousands of estrone. So that we had to abandon that study right away, trying to find a new way to give hormones. So that was years ago. So we got rid of that right away because the estrogen was just too high.
Now, why do you not like DHEA? It can convert into estrogen?
It can turn into estrone, yeah.
Okay.
So I'm not real keen on that. It can, through the cycle, it can go right into estrone. So I just don't use a lot of it. And people who take a lot of it, you'll see their estrogen levels are up higher.
Even using it topically? If you use the DHA topically, will that
no, topically, it's, again, you're not going through the first pass liver. You take orally is a whole different route of delivery. So
if somebody wants to take DHA, which can be helpful for adrenal glands and other things, then topically.
Probably want to try it topically. You can do it on the labia, vaginally speaking. A couple ways you could go there, but it's the oral route. And if you're going to do oral, just keep the dose, around 10, less than 25 milligrams. And you can invariably see people taking 50 to 75 or 100 milligrams because it's over the counter. We've talked a lot about estradiol and the importance of estradiol. Let's talk a little bit about progesterone. Progesterone is kind of the anti-estrogen. That's kind of how I look at it. And if you take too much progesterone, you kind of cancel out the estradiol. So progesterone it's the balancing hormone. It's the hormone that promotes apoptosis. In other words, the cells that are not healthy are removed from the system by the progesterone. So estradiol is a growth factor. Testosterone is a growth factor. DHEA is a growth factor, anabolic. And then progesterone is the anti-growth. It allows things to die. Programmed death is promoted by progesterone. So you just have to have that balance. And so you do the math and you say, well, how much 20 to 1 is kind of what Mother Nature has put together on that scale. So on day 20, 21, so the first 2 weeks, there's no progesterone. Women build their estradiol. And then on days 16 through 24, the progesterone starts to peak. And that's really the only time there's progesterone. And you look at the ratio on day 20, 21, you do the math. As long as it's around 20 to 1, you're in pretty good shape. So progesterone is important. It balances out estrogen. It promotes cell death and cleanup. It's going to be and it also promotes relaxation. I have heard a few women say they don't do well on progesterone. It makes them depressed. It makes them tired. Oh, God, fatigued, tired, weepy, cry, unhappy, depressed. Progesterone is tough, and some people are very sensitive to it. And when that happens, you've got to lower the estrogen and keep the progesterone low, and you just have to kind of keep that balance going, even though you can't use as much estradiol as you want to because they can't tolerate the progesterone. And I have a lot of people like that. But you would still say they need the progesterone. You can't just do estradiol. I have people come in and the doctor says, well, you had a hysterectomy. You don't need progesterone. And I said, well, does he know you still have 2 breasts? The answer is, what's he thinking about? You have these breast tissue that's supposed to cycle. It goes through 4 distinct physiologic cycles in a month, and it needs the progesterone to clean up, to cause cell death, to get rid of defective cells. That's what that's for. So no, you need progesterone. And you also mentioned progesterone is important for bone. The estrogen breaks down the bone, and it's based on how much weight you're lifting or how much movement you're doing and how much walking and so forth. And so the bone gets remodeled based on the forces of gravity that you're experiencing at the time. So women, when they get pregnant, the bones are made stronger to help support the extra 25 pounds or 50 pounds during the pregnancy, right? And then the progesterone causes the buildup of the bone, and the estrogen causes the breakdown, and that's the balance. Women are complicated. Ask any guy. He'll tell you. Well, this was great, Dr. Mathis. I am so appreciative of you coming on and answering all these questions. You're welcome. I will link all of your information down below. And if somebody wants to get in touch with you, they can call you. And I know you always answer your phone, which is incredible. Yep. You have helped so many of my viewers. I'm so appreciative of you. I can't even put it into words. I get emails from women almost daily telling me they reached out to you. And it's heartwarming that you help these women so much. So thank you so much. You're welcome. You're welcome.